Thank you everyone for joining us for today's webinar. We'll be starting in just about 35 seconds to give folks a chance to jump on here. Okay, so we'll go ahead and get started. Welcome everyone, and thank you for joining us for today's discussion on behavioral treatment impacting diabetes risk and management in the visit. So I'll be introducing our guest in just a moment, but just to say hello to everyone, my name is Andrew Phillip. I'm the Senior Director for Clinical and Population Health here at the Primary Care Development Corporation. And just a little bit about us, we're a PCDC is a national nonprofit started here in New York City, but we work in almost all the states across the country to really enhance primary care nationally, but also invest in promoting health equity and just better care in all of the areas that touch and are touched by primary care. And just a quick note, our webinar today is sponsored by SAMHSA. I'll talk more about that in a moment. But please note that none of the content that we'll be discussing here today is of the views of the Substance Abuse and Mental Health Service Administration or any other branch of the federal government. As I mentioned, this is part of a broader initiative. You may already be familiar with the work of the SAMHSA-sponsored Center of Excellence for Integrated Health Solutions. This is really has for years been a national home for training and technical assistance related to the integration of primary and behavioral health care. And through the center, you can access a whole host of resources, including information on workforce solutions, on organizational capacity and readiness for integrated care, trainings, and other resources. And so if you've been following the work of the center, a few months ago, actually in January, we offered an initial training on kind of an overview of primary care behavioral health integration, and there's also been a few other offerings on this. These are all archived on the Center of Excellence website. And today we're really looking towards moving kind of beyond this idea of 101 of why are we doing integrated care and why is this valuable, and move into more specific application of this information. And we're really going to focus on diabetes. And this really marks the start of a 7-part series that if you're on this webinar, you've already received invitations and will continue to receive invitations to join us for. And so we're focusing on addressing diabetes within the context of integrated behavioral health. And kind of the real purpose of all this is the end goal is to help you and nationally to improve the work of improving screening and management for diabetes. But we want to do this in a way that really values and maximizes the value of everyone on the team. So whether you have a staff of 5 different healthcare specialties in your integrated care clinic, or if it's just you and you're a solo practitioner, we want you to be able to walk away from this with something new that you can build into your practice. Again, whether or not it's figuring out how to involve all the members of the care team, or just how to incorporate lessons learned from each of these members of the care team into your own work. And we're also going to be taking a look over the next few months at not only the clinical competencies, but also the processes and the workflows and other components of care that are really required to do this and to do it well. So today we'll be talking about behavioral treatment. On next month's webinar, we'll be talking from a prescriber perspective. After that, we'll be going over, we'll be bringing nutritionists and talking about nutrition and food security and really promoting healthy behaviors in the context of addressing diabetes. We'll go over, we'll bring in a pharmacy perspective and talk about integrating not only pharmacy, but pharmacy and clinical pharmacist-based principles into providing care. We'll talk about a quality improvement lens. We'll address billing and reimbursement. We'll talk about how do you develop clinical pathways to really bring in a full range of specialties and our patients as well in addressing diabetes. And throughout this discussion, we'll be incorporating the perspectives of people with lived experience, including peer support specialists. So very briefly, why are we talking about this? Well, we know that individuals with behavioral health concerns are disproportionately more likely to struggle with diabetes or to be diagnosed with diabetes, but also associated with metabolic conditions. And we know that there's a double edge to this. We know that people who have behavioral health conditions need these services, but we also know that people who are receiving services specifically for behavioral health needs are also less likely to receive the flip side of that, which is services related to diabetes and chronic medical conditions. We also know that behavioral health providers are uniquely positioned to really address this through using skills they already have that Amy will talk about today around health behavior change, but also as change makers in general, as leaders among teams, and again, with working with a population who really needs these services. And we also know that as we move towards the future of integrated care, more and more we're not talking only about integrating services, but also integrating types of metrics and measures that these services are being valued and judged upon. So without further ado, I want to introduce our excellent presenter for today. This is Dr. Amy Walters. Dr. Walters is a clinical health psychologist and consultant. She serves as the Director of Behavioral Health Services for St. Luke's Humphreys Diabetes Center and as a consultant to St. Luke's Children's Integrative Medicine Program. Dr. Walters works with patients to address emotional and behavioral factors which negatively impact health and chronic disease management. She provides professional presentations like today's on behavioral health integration, motivational interviewing, and other psychological factors that impact chronic disease. She received her PhD from Utah State University and brings over 20 years of experience working in clinical and community settings with adult and pediatric populations. She's active with the Idaho Psychological Association and the American Psychological Association. And she volunteers as a psychosocial director for Idaho Diabetes Youth Programs. And she may also talk today. She's also a noted mom of a child with diabetes, and I think really helps inform some of the work, and hopefully we could hear about a little bit of that today too. So without further ado, welcome Dr. Amy Walters.
Thank you so much, Andrew, and thank you everyone for joining us today. I'm excited to be here. I feel very passionate about being able to share the experience that I have in working with people with diabetes, and really believe in the importance of behavioral health support for our patients with both type 1 and type 2 diabetes. So thought it might be helpful for us to start today's conversation with some case examples of individuals who I frequently see in the Diabetes Center and in my work in some of our rural clinics. And we'll use those throughout today's presentation just to talk a little bit about some of the interventions that might be helpful in these different scenarios. So case number one is a 62-year-old female who has type 1 diabetes and is struggling to afford medication and not taking them regularly. Case number two, 45-year-old male who has type 2 diabetes, hypertension, obesity, and really struggling with sedentary behavior. Case number three, a 37-year-old female who has type 2 diabetes, is not following a recommended low carbohydrate diet and often engages in emotional eating. And case number four would be a 16-year-old male who has type 1 diabetes, A1C of 13, fights with parents about diabetes management, and really struggling in school. So these are some examples of patients that may present, and we're going to talk a little bit about some interventions we could use that might be of assistance with these people. Next slide. So when we talk about diabetes treatment, I like to level set and try to just get everybody on the same page with kind of areas of focus. One of the most challenging things about managing diabetes, both type 1 and type 2, is this balance of juggling the dietary piece, which a lot of people focus on, along with maintaining regular exercise and adequate levels, and then the medications that go along with diabetes management, and the self-monitoring, checking glucose levels to see if what we're doing is helping. So we want to be thinking as a behavioral health provider about each one of these three areas and different opportunities we might have to intervene along the way. Next slide. There's the juggle of the three. So treatment overview, being able to have a foundational knowledge in diabetes as a behavioral health provider is critical. There's a language of diabetes that we speak. There's a vocabulary behind it. And being able to understand the general treatment guidelines is going to be important for creating kind of street credibility with both your patients and your providers. So in general, for patients with both type 1 and type 2 diabetes, we find that following a lower carbohydrate diet is really helpful in maintaining glucose levels. So we want to make sure our patients have an understanding of which foods contain carbohydrates, what a serving size is, and how to calculate at least general estimates of what they're having in each meal. Targets that we typically use are around 45 grams or less of carbohydrate if you're trying to just maintain glucose levels, and 30 grams per meal or less if you're trying to lose weight. And when you start calculating carbohydrates, you start to see this is pretty easy to reach and very easy to go over. Typical meal at McDonald's, you're going to have your total daily carbohydrate intake in just one meal. So making sure that as a provider, we understand these guidelines and that we can talk with patients about some of their current dietary habits and how they're following along these lines. The next key area is physical activity. Oh, sorry, back to the other slide, please. The physical activity is going to be important for working on insulin resistance. It's also going to bring our glucose levels down, burning some of those carbohydrates, and will definitely help with metabolic rate and getting that up. Many of our patients with diabetes struggle with weight management as well. So talking with people about the importance of physical activity. General guideline is 150 minutes a week of total activity with 30 minutes a day, at least 5 days a week. So we want to not be front loading and doing it all one day, but having it multiple days a week. This is cumulative, and that's important to know and to talk about when we're working with people on behavior change. If you're someone who has a very sedentary lifestyle, which we often see this among patients with diabetes, that may feel like a lot, especially if you're used to spending a lot of time sitting in a chair. So starting low and slow is important. Being able to build up to that and knowing that this is cumulative. So 10 minutes here, 10 minutes there, 15 minutes there, all adds up and can be important. And then our final area that we want to be focusing with people on is medication adherence. So this varies depending on the type of diabetes that you have. Our type 1 patients go on multiple daily injections of insulin right away to cover their food levels and also adjust based on glycemic level. For our type 2 patients, many of them will start on oral medications, may transition into some of the different injectables like our GLP-1s, and then may eventually end up on insulin. Diabetes is a progressive disease. I'd just like to put a caveat in there. Many people feel like it's a failure when they go on insulin, and that's an important dynamic for us to be aware of, as it may just be the medication and the treatment that they're needing at that time. So we want to be ready to talk about that as well. So these are our 3 areas for intervention that we're wanting to make sure we're addressing with our patients around behavior change. Next slide. In addition to the physiology of diabetes, which is what oftentimes we're focusing on, there are a number of other areas of impact besides just physical health. And I talk about this with all chronic conditions because there are many opportunities for behavioral health providers to intervene here. And it's important that we have an awareness of these different areas because they may be interfering with overall management of the chronic condition. There's been a lot of news recently about the soaring cost of insulin. Diabetes is a very expensive disease. Patients are having to afford medications, test strips for checking glucose levels. We have a great technology available in diabetes with insulin pumps and continuous glucose management systems, but all of those things are very expensive. In my work in some of our more rural areas, I've often seen this as a key barrier that isn't always brought up in the initial visit. So making sure that we're asking questions about the financial impact the disease is having and how well people are doing with affording their medications. Career can be a significant area of impact. Patients will often talk about their jobs are not well supportive of their need for their self-management, whether it's testing their glucose levels, having regular meals, following a regular routine. This can be a significant area of impact. The mental impact. We know that cognition is affected by glycemic control. We see issues with various areas of executive function, so memory, concentration, sequencing can all be affected as glucose levels are going up and going down. In our type 1 patients, especially adolescents and children, we want to make sure that schools have accommodation plans for this in place. If our kids are struggling to achieve good glycemic control, they're having high blood sugars, they're having low blood sugars, that's going to affect their academic performance on tests. So making sure that they have those elements in place for accommodations to be able to take tests later, postpone, and have the other accommodations they may need. There's also a significant emotional impact with diabetes. We find that anxiety and depression are much more prevalent in this population, so making sure that we are doing regular screenings. In our clinics, we like to use PHQ-9 and GAD-7. Those are both public domain instruments that help us screen for these issues, and that we're treating actively, making sure that we're addressing that. There's also social impact with diabetes. When I talk with patients about changing lifestyle, this often comes up as a concern. You see that trying to change dietary habits may affect their willingness to go to family events, and they don't want to be the one person who has to say, no thank you on that, trying to eat in a more healthy way. We can see in our families with children of type 1 diabetes that the demands of self-care may change family activities. One example that I like to use, before we had children, my husband and I used to do a lot of outdoor recreation out here in Idaho in some of our remote areas. And then having a child with type 1 diabetes really affected that for us. We needed to be available by phone, and in some of the remote areas that wasn't the case. We also hesitated to bring her into the wilderness areas in case we had some kind of medical emergency. So there was this unforeseen social impact that we needed to deal with. And then as a family, when one person in the family is trying to make change, that affects everyone else. Sometimes when I'm working with some of my male patients, they'll say, gosh, my wife is a great cook, and I don't want to insult her and not eat the foods I normally eat, or tell her I can only have a certain amount, because that's kind of how we show love in our family. So really having an awareness of each of these areas of impact, how that may be affecting patients, and how we can support them to make positive changes in each of these areas. Next slide. So why do psychosocial issues come up with diabetes? When you think about a day in the life of someone with diabetes, they're constantly being bombarded from all directions with, questions of friends and family and colleagues. Did you take your medicine? Did you test your blood sugar? What did you eat? How much did you eat? Are you taking your insulin? You're not supposed to have that. And so there are these daily opportunities that come up for feelings of guilt that, wow, I know I should be doing better and I'm just not doing that. There can be a lot of shame involved when they're not making the choices they need to. There are multiple opportunities for failure when you are trying to hit a certain glycemic target, and despite your best efforts, you may not be getting there. It creates a sense of learned helplessness in people, and that can really zap their motivation. And some people start to feel resentful that, their health is working against them, that it's frustrating to have to be focusing on every bite of food they put in their mouth and following this medical regimen, taking money out of their budget to be affording medications that are really expensive just to maintain good health. So when we look at that as a collective, it makes sense why there are so many opportunities for emotional distress that go along with this condition. Next slide. So let's take a case example. Mrs. Jones is a 48-year-old female with type 2 diabetes. She has obesity, hypertension, and hyperlipidemia. Her A1C is 10. She resides with a husband and 2 children, ages 13 and 16, high levels of stress, and uses food to cope. So emotional eating is an issue I see often in the patients that I serve. She's got concerns with work that creates stress. She's parenting her teenagers, and that's a source of stress. And then she's got aging parents. And so kind of in that juggle of taking care of herself and her family. And so she's struggling to make some lifestyle changes. Next slide. So we want to do a contextual interview when we first meet with our patients to have a good understanding of what they're struggling with. And this comes out of the work in the PCBH model, our work, love, play, health contextual interview with our 3 T's to help understand the problem. So I like to use this visual when I talk about contextual interviewing. So I'm meeting with Mrs. Jones, and I'm going to start asking some questions a little bit about her work. You know, tell me about the work that you do. Tell me about the stressors that are involved. I want to know about finances and how that may be affecting her health. We're going to ask some questions about her love relationships. How are things going in the family? What's the relationship like with children and spouse? Tell me about those aging parents and how that affects day-to-day life. Do you have time with friends? And how does that affect your diabetes management and health choices? We want to check out health in general, asking about more detailed questions about diet, about activity level, about sleep, about substance use, other chronic conditions, how the relationship's going with the healthcare providers. And then what is she doing for fun? And oftentimes people are kind of surprised about why is that important? But that's where we get our motivation. What matters to us? How do we get to enjoy our time? I want to know more about the specifics of the presenting problem. So if the patient's really struggling with their adherence, I want to know more about kind of the timing of that. How long has that been going on? Are things getting better? Are things getting worse? So time, trigger, trajectory. And what are the things with the emotional eating that tend to trigger that? In Mrs. Jones's case, we know that stress is a significant factor. We may have to do some behavioral monitoring to learn more about other triggers. And then I want to ask about values, because all of this is going to be grounded in our values. And we're learning more and more about the importance of values in clinical interventions, both motivational interviewing, primary care behavioral health model, ACT and FACT, all of these theoretical approaches really focus on the importance of values. So we want to make sure within the context of our interview that we're checking that out a little bit. Next slide. So when it comes to intervention, there are really kind of 5 main areas that I find myself working around. And we're going to go into these each a little bit and talk about some different strategies. So definitely working on lifestyle change. The providers in my clinic often come and get me when patients are struggling to make dietary change, to get more active. They also struggle with medical adherence, and we're going to talk a little more about that and the prevalence of that and how, as behavioral health providers, we can assist. We want to be looking at mood screening and support, because we know anxiety and depression are so prevalent in this population. We want to make sure we're addressing those issues. We talk about coping with chronic disease. There's a lot of grief and loss that's involved in dealing with a chronic health condition. Patients can struggle with burnout, so we want to be addressing that in our work. And then finally, stress management and the impact that stress has on glycemic control. So let's jump into this. Let's start with behavior change. The first point that I would like to make to both patients and professionals is that behavior change is hard. It's our natural instinct to repeat the same patterns over and over again. And if left to our own devices, what we're going to do is what we're used to doing. So I use a lot of motivational interviewing to help people explore some of their current behavior patterns and problem solve some of the barriers around that in a very non-judgmental way. I'll also use a lot of behavior modification and strategies from CBT around understanding just the nature of the behavior itself, looking into what are some of the triggers for that behavior, what drives it and kind of keeps it going, and what are some of the maintaining consequences. And one of the nice ways to start looking at this is really through self-monitoring. Sometimes just having someone keep a log about, for emotional eating, for example, starting to track, you know, when is it happening? What's happening before that? How are you feeling? What happens afterwards? Can create a lot of insight and can actually be an intervention in and of itself. And so I'll use a functional assessment approach, looking at the ABCE elements of the situation. So affect, behavior, cognition, and environment. Next slide. We want to look at the nature and function of that behavior, and sometimes just talking with patients a little bit about this, providing them with some basic understanding of why we care about these elements. They can start to see the patterns and how there's a trigger in their environment, and then we can do interventions to learn to avoid that trigger. that there's some kind of an unmet need that really is driving this behavior. And then there's some kind of consequence that seems to maintain it. It's reinforcing in some way or we wouldn't be doing it. So helping patients achieve an understanding of each one of these elements can help them learn to problem solve and use these skills as these issues come up over time. Next slide. So I'll often use a graphic that I call the behavior pyramid. So if you think about a three-dimensional pyramid, you have 4 different sides. You have the behavior itself, you have this affective or feeling component, you have a cognitive or a thinking component, and then you have this environment, which is kind of that foundation of that pyramid, that base that it all starts in. And if we could train patients to start thinking about things this way, they can get a little distance on the behavior itself and start to understand these basic components, and that can really help us determine some different strategies for intervention. So we're going to look at this as one of our examples. So let's go to the next slide. So if we take Mrs. Jones's case and we do a functional assessment there, behaviorally, what she's told us is that she tends to avoid exercise. She has a rough day and she comes home and will do emotional eating, which involves binging typically on some kind of a snack food like chips or chocolate. This often starts with a cycle of a thought when she walks in the door: I can't handle this, this is too hard, chocolate's going to help. It comes up when she's feeling stressed or overwhelmed or tired. And the environment contributes because she's in this environment that has a lot of high demands between the demands of her work and her children and her aging parents. She has limited resources for time and energy in dealing with those things, and she lives in a very food-rich environment. Mrs. Jones keeps a hearty stash of chips, candy, and other stress-related foods at home in her pantry, and her pattern is when she walks in the door, she stops by the pantry, grabs her favorite snack, sits on the couch, and decompresses with her favorite treat. Next slide. So as we're talking through this process with Mrs. Jones and we're identifying these A, B, C, E elements, we can start to come up with different intervention ideas at each level. So environment is often our easiest place to start. This can be your low-hanging fruit. And if we can set up this environment for success, that can be an intervention all in and of itself. So for example, maybe we talk with Mrs. Jones about maybe we need to get rid of that snack cupboard and replace it with some other things instead. So if we get the chips and the chocolate out and instead we fill the refrigerator with some healthy snack options, fruits and veggies that are already prepped, ready to go, things she likes, she's going to have a lot more success. We want to address the affective piece. So what are the triggers for stress? What are the ways that you're coping with that currently? Could there be other ways that we could learn to cope in a healthy way and really work on some stress management skills around that emotional distress? We want to come up with some alternative coping behaviors. Right now, the pattern is we walk in the door, we go to the pantry, we sit on the couch. If we change that up a little bit, using some other healthy coping behaviors, like maybe when we get home, we have our tennis shoes by the door and we take a quick walk to kind of decompress and think about our day. Or maybe we call a friend and talk about what's been happening. Mrs. Jones could sit down with a journal and journal for 10 to 15 minutes about what she experienced during the day, what came up, how she wants to problem solve that. Or we could just work on some breathing, really just doing something else to physiologically calm herself at the end of the day instead of using food as a calming strategy. And then I would talk with Mrs. Jones a little bit about some of her cognition, some of those thought patterns that are setting her up for her emotional eating, really shifting that self-talk from the things that she can't do to the things that she can do. I can ask for help from others. I can reduce some of my demands. Maybe I need to say no a little bit more often, or maybe I need to create some structure around when I can help my parents instead of just being available at the drop of the hat each time they call. I can remind myself that I've been through worse, that this isn't going to last forever, and that it's going to be okay, and that I have the skills I need to handle these issues. Next slide. Finally, when we're working on behavior change, I like patients to have a realistic expectation for what this looks like. what we tend to expect is that we start here and that we just make this great upward progress in a nice linear fashion, and that's never what happens. People usually are gung-ho in the beginning, so they start making some nice change, and then something happens and they go crashing down. They can use those same skills that they learned when they first started to kind of get back up and get moving again, and then there's going to be another dip, and that this up and down pattern is typical, that it's not failure, that it's very normal human behavior, and that when we have that expectation, we can work towards identifying what are the triggers that send us crashing down, and what are the strategies that help us get back up, and remember that so that in the future, when they're doing this up and down pattern, they can be more successful and have a more positive outlook. Next slide. So some specific interventions to really support healthy eating, really addressing that low-hanging fruit first, early success. Sugar, soda, fast food tend to be big culprits. If we can work with people on shifting those, increasing more healthy produce in the home, having it readily available. If they're going to have junk, put it on the highest shelf in the pantry, make it hard to get to, make that produce up front and center and easy. I let the patients choose the area that they want to start. After we do a contextual interview, I will kind of offer them a menu and say, based on the things that you shared, it looks like we've got a lot of great opportunities for improving your glycemic control. We could talk about changing your activity level. We could work on your sleep. We could work on some stress management. We could talk about dietary change. Where would you like to start? What sounds good to you? We will start with a food log. There's a lot of great evidence behind the importance of that self-monitoring skill. Just tracking what you're eating, how much you're eating. Portion size is really important here. We all tend to underestimate that. And then sometimes I'll have people do an advanced food log, especially if we're doing a lot of emotional eating. Having somebody really track, what are the thoughts when you're engaging in that snacking? How are you feeling? Kind of where are you? Start taking some notes about that. That'll help us understand that pattern. We want to work on stress management, and then using that functional assessment to start understanding some of those patterns and then developing those healthy coping strategies, just like we talked with in our case example. Next slide. So adherence is always something that I like to touch on. We expect good adherence from our patients, but what we know from the literature is that most adherence rates are less than 50%. So that tells us that the vast majority of people we see are not adherent to their medical regimen. So poor adherence is the norm, not the exception. So I'll often just normalize this for patients, really helps reduce some of the guilt and shame, helps motivate them towards making some improvement here. We also know that self-report of adherence is not the best. We like to present ourselves in a good light, especially to our providers. So really getting that data, having people track with the log, reviewing glycemic measures through their monitors, their CGMs, is going to be important to have a good understanding. And I like to remind my providers that if people report one thing and then the data shows something else, it's not that they're lying, it's just human nature. We just tend to over-report and think of ourselves in the best light. So be sure and get that data. With our pediatric population, it's important to remember that adherence really declines during adolescence. This is just a tough time to manage diabetes and other chronic conditions. So we want to anticipate that, be prepared for it, and be ready to intervene. Next slide. So some ways to improve adherence include using that contextual interview, really working to understand the context of the situation and what might be interfering with the adherence. We can use that functional assessment. What are some of the barriers that are coming up? Are these internal barriers? They don't feel motivated, they're burned out, or maybe it's an external barrier. I don't have test strips, I forget my meter and I'm out to eat and I just skip it. Maybe I'm embarrassed to test my blood sugar in front of other people, so I'm not doing that adequately. Maybe there's a financial reason. I just can't afford my insulin. As insulin prices are skyrocketing over and over again on a daily basis, I see patients come into the clinic who are taking just enough insulin to get by, but not taking their full dose. They're alternating doses, all kinds of things because of the financial impact. We want to make sure patients understand instructions and how to adequately take their medications and test their glucose levels. It's always amazing to me how We feel like we've done a great job educating, and then I'll ask somebody to show me how they do something. We actually had a gentleman in our clinic who was on an insulin pen, and when he would inject, he was not taking the cap off the needle. So he thought he was getting the insulin, but it wasn't being administered. Sometimes transportation to medical appointments can be a barrier. Sometimes avoidance. This is a common pattern with behaviors we don't want to do. Nobody wants to limit what they're eating. Taking shots is no fun, so we can get into these avoidance patterns. There can also be kind of a negative reinforcement where when I avoid, it feels really good, but then that creates more problems later. So understanding kind of the function of that behavior, is it control, is it avoidance, is it something else, can help us understand. I have revenge in there, which sounds kind of crazy, but sometimes with our adolescent patients, they intentionally don't take care of themselves because they feel like they're getting back with their provider, they're getting back with their parents, they're getting back with diabetes. It just doesn't work out well in the end. So helping really problem solve some of these physical barriers. And with the internal barriers, we want to use motivational interviewing. Acceptance commitment therapy is great for really clarifying those values, helping people understand, is what you're doing workable? Is it going to get you where you want to go in the end? Or is this going to take us down a path that really is not something that you want to see yourself doing in the next 5 to 10 years? So working through those things can really improve our adherence. Okay, next slide. So I talk about the facts of behavior change, really helping people understand this thought, feeling, behavior relationship, and how maintaining consequences enter in. So this is just kind of your basic elements of CBT and another way of thinking about it, and helping people understand that this can move in a very positive direction towards our goals, or it can move in a negative direction and really sabotage our goals. And I start with feelings because oftentimes this is where people connect. Makes sense to them, they can report to you how they're feeling, and then we talk about the behaviors and the maintaining consequences, and then we kind of back into this thinking part, trying to help them understand how those thoughts may actually drive this whole system. Next slide. With mood screening and support, as I mentioned previously, anxiety and depression are just higher among our diabetes population. We see this in 30 to 50% of patients. So it becomes really critical during our primary care visits that we're screening because we know that mood issues can really interfere with adherence, glycemic control. Depression tends to really zap energy, and people often avoid exercise when that's the case. They lose that desire to make those behavior changes. It is important to differentiate when we're doing that between disease distress and depression. They can look the same, but it can be helpful to use a tool like the PAID, the Problem Areas in Diabetes Scale, to look at, is this just distress related to their diabetes, or is it distress across the board? And we do at least annual screenings, but we can also use these tools to kind of progress monitor and see how we're coming along. So again, many tools out there that are fantastic. Many of the clinics that I work in will use PHQ-9 for depression, GAD-7 for anxiety. I always like to include an anxiety measure because anxiety tends to lead to avoidance behaviors, and it's one that isn't talked about as often as depression. But in one of our clinics, we actually did a quick study and found that 50% of our patients with diabetes were presenting with significant levels of anxiety. So I want to make sure we address that as well. Next slide. So we want to talk with our patients about just how are they doing with their coping. Chronic disease is a tough one. It's not for sissies. It takes a lot of time and energy and focus and to maintain that motivation. And grief and loss are very prevalent issues among our patients. They often don't think about chronic disease as something that causes loss, but the loss of good health, especially for patients who are in their 20s, 30s, and 40s, is not always something that they're anticipating. So being able to address that and really validate that has a lot of value in treatment. I use what I call the 5 brass keys to success and wellness for patients with diabetes. The first one is balance. Diabetes is definitely a disease of moderation, and so learning how to keep balance in your diet, balance with your activity level, Balancing your expectations. If you're expecting yourself to have perfect glucose levels all the time, that's often a setup for disaster. So instead, helping people understand the relationship, how their actions are affecting their glucose levels, how they can use moderation and still enjoy some of those things in their life, but also manage their diabetes effectively. That goes right into that realistic expectations. Setting goals that are reasonable, having realistic expectations about what they can do. If they have a very sedentary lifestyle, asking a patient to jump to 30 minutes a day of physical activity is unrealistic. So instead, we just talk about that next step. So for example, if it's someone I'm working with who does no physical activity and they're sedentary, I may have them stand during the commercials as they're watching TV. And then we're going to take that next step in shaping that behavior to, maybe they're going to walk around their house. And then maybe they're going to walk out to the mailbox, and then they're going to start walking around the block. And so we just gradually take baby steps so that they can have success along the way, which will start to build that motivation. And as they start to see that connection and improvement, it makes a big difference. Attitude is critical. You got to have an optimistic attitude. We need to really practice that self-compassion. This is a hard disease, and there's going to be a lot of opportunities for failure, a lot of opportunities to mess up, and that's okay, that we don't have to throw the baby out with the bathwater. It's just we just take the next opportunity to do something positive. Trying to look at their numbers in an objective way, I find, is also really critical. Patients will see the measures on their meter, and they look at a blood sugar and they see a 200 and they feel like it's an F on a report card. We try to create more objectivity and just talk about, this is a number that drives success. It helps you know what you need to do next. It's going to inform our treatment and help us kind of understand where to go from here, not taking it as a measure of success or failure, but instead, this is just a number that informs our treatment. We know that support is critical for people with chronic disease, and having both a great personal support team as well as a professional support team, they're going to have the best outcomes in the long run. And then we want to work on stress management, and we're going to talk about that here in a minute, with the importance of coping and stress management for good glycemic control. So these are our 5 brass keys, and sometimes just providing this as a handout and then talking around that and how they're doing in each area can really help with that coping piece. Next slide. So my last of my 5 areas is stress management. It's human nature to avoid discomfort, to do what's easy and feels good, but that doesn't always support our good health behaviors. And living with chronic disease is stressful. We also know that the physiology of stress, so that fight or flight response that's triggered, has a negative impact on glycemic control, because we end up boosting glucose levels in the bloodstream with that fight or flight response. So teaching patients about that physiology, that when they're stressed, their glucose levels are going to run higher, learning to be proactive and having a good stress management plan. And oftentimes, we don't have to be fancy with this. If we can come up with 3 or 4 things that can be go-to strategies for them in managing their stress, that can be an effective strategy. So, walking, having some kind of movement, going for a daily walk at work if that's a stressful time for you, making sure that we're building in time with family and friends, using some deep breathing or meditation, time in nature, music and art, whatever it is, brainstorm a list of good ideas and go-to strategies. I'll often have people keep a little card in their wallet of kind of what they can do, and especially for my patients that struggle with emotional eating, we talk about, let's do 3 things first before we turn to the food. Next slide. So overall, behavioral intervention is really about helping people with the lifestyle change piece. As behavioral health providers, we've got great expertise in behavior change, in motivation, in understanding emotion and cognition, and we can use all of that knowledge to help people make successive lifestyle change, and then to maintain it, because that's half the battle. Recognizing that adherence is just part of the process, and that it's going to go up and down, that's okay. And if people can understand what are the things that help them be successful, what are the triggers that send them down, they're going to be well armed with ways to address that. We want to keep an eye on that mood, doing our regular screening, helping people have strategies for boosting their mood, doing value-based activities that are going to keep them engaged in their life and keep that motivation going, teaching them some basic coping strategies for dealing with chronic disease, and really addressing stress management. Next slide. All right, we are to our Q&A, so we'll go ahead and open that up.
Okay, great. So we have a couple of questions that have come in, and thanks, Amy, that was great. The first one was really around resources, which I think is, there's a lot of ways to apply this. The specific question was around patient education resources that folks can pull from to use in their clinical encounters, but also curious if you have any other kind of go-to resources, particularly for behavioral health clinicians who are newer to talking about diabetes.
Yeah, absolutely. There are a number of great texts out there on behavioral health integration and working on behavioral strategies. Definitely, Chris Hunter's book is a great one. There are several out there by Patty Robertson and Kirk Strassel. So just understanding kind of the foundational knowledge in health behavior change provides a nice framework. And then learning more about diabetes specifically. So different websites, American Diabetes Association, the ADA. If you're going to be working with diabetes patients, it's really important that you understand some of the physiology behind diabetes, that you understand the language of diabetes, that you understand the different medications and how they're used, and how to kind of communicate with patients in that way. And I know Andrew has a great list of resources that are included at the end of the slide that we'll share with you.
Yes. So we'll have these. There we have our whole list of references there. And another, just for reference, we'll have all of today's slides will be available in archive both at the SAMHSA Center of Excellence website, which I shared the link for in the chat, and you'll also receive over email as well as PCDC's website. We have some specific questions that came in. I think it was an interesting one around specifically building in some plans to reinforce behavior. And so the question was, do you see value in creating a list of positive rewards to really get at that adherence issue? For example, like a spa or massage treatment, a movie, healthy dinner out, et cetera, to really kind of boost that behavior?
Absolutely. I'm so glad you brought that up. So yes, especially when you think about looking at motivation, we have internal motivation and external motivation. Some people are highly internally motivated to get going and do it, and that's great. But I would say the majority of people that I see struggle with that motivation. So having some kind of a concrete motivator using behavior modification strategies can absolutely be effective. I had one woman that I worked with that was really, really struggling, and finances were an issue. And so I had her bring in her grocery list for a week. Each time she would bring in not just the list, but the receipts. And we would go through that with a highlighter and identify any foods that were purchased that were not very diabetes friendly. And then we would look at the dollar amount spent and just adding that up and saying, now what if next time you go to the store, instead of putting it in the cart, you just write it down, and then you get to put that money in a jar to spend on whatever you want. And for her, it was going and getting a manicure and pedicure. That was something she felt she couldn't afford, but just one trip to the grocery store, not buying her chips, soda, cookies, and ice cream, paid for her manicure and pedicure for the week. And it was something positive she was doing for herself, for great self-care, and it was definitely helping her glycemic control. So sometimes just being creative and helping people find those strategies is a great way to do it. So yeah, firm believer in that.
And I think this is another kind of nice follow-on to this. And so there's a question about specifically coping with tricky situations. And we know this comes up a lot with weight management in general, but certainly with diabetes. So for example, in situations where maybe it's there's like some family pressures or at some sort of event, what are some coping strategies for these kinds of situations when someone's really trying to eat healthfully for managing their diabetes?
Yeah, so great question. So one of the skills that I work on regularly with patients is actually assertive communication. Many people struggle with how to be assertive. How do you do that without being rude? We want to be mindful of kind of those social dynamics. So really role playing some of those scenarios, like what's your worst nightmare? And then let's just act it out and kind of talk about what you could say and how you could say that in a way that you could get support from those people, as opposed to feeling like you're out of place or feeling under pressure. We talk a lot about creating a supportive environment. So if you're working hard at making healthier food choices and you're going to a potluck, what can you bring so that you know you have something to eat? So for example, recently we've been talking about Super Bowl. That wasn't that long ago. And so a lot of patients were struggling with that. So coming up with an idea like, gosh, maybe you can bring a veggie plate, or maybe you can bring, a large fruit plate, or what other option could you bring? Because there are oftentimes many people who want a healthier option. And then the other thing is really pulling in that social support. So instead of just trying to do it alone, get a buddy, get somebody to do it with you. So whether it's a friend, a spouse, maybe it's the host of the party, maybe you just say to that person in advance, I know you have made great food, but I'm really working on controlling my diabetes. So please don't be offended if I'm not, trying your cake because, my doctor's been pretty adamant that I need to cut back. So just paving the way for that a little bit can really create an easier environment to navigate.
Great. We've got an interesting question around screening. And so I think this is also kind of cuts to some of this, the intricacies around just integrating care. But how do you choose between, or kind of talk through the pros and cons of using more of like a generic mood screener, something like the PHQ-9 or GAD-7, versus a diabetes-specific screener? And the example I was given here was a diabetes distress scale. To use both, one or the other. Obviously, we have limited time and resources.
So in the Diabetes Center, we give all patients PHQ-9, GAD-7. We do an SBIRT to quickly screen substance use, because those are the top three when it comes to mental health issues that we see among our population. And then for a first appointment, I give everybody the PAID, because I want to know how they're doing with their diabetes management. It also has great specific questions that helps you target more directly different areas of intervention that have been a challenge for them. It also allows me to differentiate, is this, sometimes the anxiety and depression scales are high, but if the PAID is really high, it helps me differentiate, is this across the board or is this more diabetes specific, and vice versa. If you don't have time to do all of them, I would definitely start with an anxiety and depression screening. And then if you're getting a sense that there's something going on with diabetes distress, you could administer that, as well as a whole other host of tools. We have a number of tools. For example, in our geriatric population, oftentimes cognition is a concern, and so tests like the MOCA can be available and used in a screening setting to help direct different kinds of referrals that we might need to make. And I'll do those based on what comes up in the contextual interview.
Great. So there's some, we're having a lot of questions come in. There's no way we're going to get to all of them, but I'd encourage folks to continue sending them in, because we can respond to them after the webinar.
Yeah.
The next question we have here, I'm sort of jumping through a list, but I think some interesting questions around groups. So can you talk about applying some of these things to groups, and then also a little bit about who facilitates the groups and is participating? For example, behavioral health clinician, bringing in people with lived experience. What's your experience with that?
Yeah, absolutely. So I ran what I called a walk and talk group in our diabetes clinic for 8 years. And I didn't anticipate starting that long, but it just kind of worked out that way. So this was a group, which was an open group where people were able to come and go as they wished. We did 30 minutes of education and kind of support group style, and then a 30-minute walk afterwards. I started it because a number of our patients, especially within our geriatric population, were really struggling to get started on that physical activity. So people were able to walk whatever length of time worked for them, and that some people walked for 10 minutes, some people walked for 30, but it was a way to get started and kind of help shape that behavior. During that time, I facilitated the group, but I would often have guest speakers. So we would have one of our dietitians come in periodically and talk about different topics. Sometimes we had our providers come in and talk about a topic like neuropathy, eye disease, some of the other complication issues. So definitely a great opportunity to touch more patients when you're able to do a group setting like that. And I've had great success with kind of that open group where people don't have to commit to coming every week. They can just kind of come as they please. My best success story with that group is I had a gentleman who came, and he was very mindful of his money, and he did not want to have to pay for behavioral health appointments, but he would come to groups. So it was a way for him to do that. And over the course of 2 years, he actually lost 100 pounds just participating in our group, and was able to keep it off for the 8-year duration of the group.
Excellent. Yeah, and just a real plug for groups. I mean, for diabetes, for weight management, for a host of other things, we see a lot of success in bringing in other disciplines as well. We've had a few questions that are really centered around addressing social determinants of health, bringing in considerations around from health literacy to homelessness. How does that kind of weave in, and how do you get around things that are in that way very very concrete, like access to quality food and a place to sleep?
No, it's such a great point, and I feel like so many of these things, we could have whole hour talks just on these. Social determinants of health are definitely tremendous factors, and we definitely, in our contextual interview, want to do some screening for that. So finding out about housing, finding out about access to food, food insecurity issues. A number of patients at the Diabetes Center have said over time, I have to really rely on the food pantries for our food, but they're full of high carbohydrate options. I mean, it's pretty much, rice and beans and pasta and things like that. And how am I supposed to eat healthy when I don't have a lot of money? So some of our dietitians have actually created some handouts, top 20 things for diabetes you can find in the dollar store. I mean, just different, there's different ways of doing that, but really helping patients problem solve and address what are some ways that we can, help support you. I think it's critical for BHCs to have a knowledge of the different community resources that are available. In Idaho, our school districts actually do like a self-rescue manual that's available by county that helps identify the different resources within different areas, whether it's housing or food or electric or anything like that. So having an open conversation about that, being aware of it, making sure that with the pharmaceutical companies, there are a number of patient assistance programs for most of the pharmaceutical companies. So how to access those, how to help patients apply. We definitely want to be addressing those factors. And then just recognizing, I think, kind of the high risk nature, definitely our patients who are struggling with homelessness, who some of our patients with severe and persistent mental illness are taking medications that really affect their glycemic control and insulin resistance. So having an awareness of how those different factors are going to impact diabetes.
Yeah, no, great points. And I think also getting into the complexity of this. And we will be bringing in, we'll be continuing this conversation next month. We'll talk specifically about prescribing and the relationship with diabetes. People's interest with the diabetes distress scale. And so we've had a few questions about this. Can you talk a bit more about, do you administer this at every visit? Is it periodic? Can you use it with type 1 and type 2 diabetes? Is it really just for one?
So, yes, can use it with both type 1 and type 2. This came out of Joslin Diabetes Center. And it's just, there are a couple of different ones out there. This is one I've liked to use. It's about, don't quote me on it, 20-ish items. I usually do it as a first visit to kind of get a sense of where people are. And then I will use it, if it's a patient that I see for follow-up therapy, I'll often administer it again around, if we do about 6 sessions around that time, just to kind of see how we're doing. So in our center, we have kind of a blended model where we're doing more traditional BHC work as well as some traditional therapy. And so I would use it in that context.
Great. So we're down to our last minute and maybe 10 seconds here. So I do want to give a quick nod. Again, this is part of a larger series and we'll be continuing every month through the summer. And there's a host of other resources available through the SAMHSA Center for Integrated Health Solutions. You have those here on your screen. And these include other learning communities and Project Echo style models. You can also catch me and others at NAPCon coming up if you're heading to that conference in April. Also the conference that Dr. Walters mentioned, which is the Idaho Integrated Behavioral Health Network Conference. If you're out in Idaho, this will be in Boise this year, we'll be there as well, and Amy will be there too. And that's April 1st, 2020 in Boise. So we hope to see you all there. Dr. Walters, thank you. Any parting comments for the folks tuning in today?
Yeah, so thank you for talking about the IABHN conference. This is a great conference with just a host of fabulous speakers. If you want to learn more about diabetes, I will be doing a 4-part series on diabetes that'll be available that time too. And I just appreciate everybody, tuning in and taking their time today. This is such an important area for intervention. I feel like there's just a wealth of opportunities for behavioral health support, and can't say enough how critical I think it is. So thank you for your interest in the topic.
Great. Well, thank you, Dr. Walters, for this expert commentary, and thank you, of course, to everyone who's joined us today. Thank you to SAMHSA and to the National Council for Behavioral Health, the home of the SAMHSA Center of Excellence for Integrated Health Solutions, and continue to join us, the Primary Care Development Corporation, for the 6 remaining parts of this series. Where here you have both Dr. Walters and my email address. Feel free to stay in touch with us, and we hope to see you next month for part 2. Thanks, everyone.
Thank you.